Hello, my name is Andrew Duffy. I'm an associate professor at Yale and a minimally invasive GI surgeon. My topic today is acute appendicitis, to operate or not. These are my disclosures. I work as a consultant for Medtronic and Bard and on a surgeon advisory board for Intuitive. There's been a lot of questions asked and answered over the years regarding acute appendicitis. How long can we wait before surgery in a patient who clearly presents with acute appendicitis? Are minimally invasive approaches appropriate? In which settings are they appropriate? Can phlegmonous appendicitis be treated with antibiotics? Is there a role for surgery or interventional radiology for abscess and perforated appendicitis? Is there a role for interval appendectomy? What's the role of CT and ultrasound in diagnosis? If we're doing a laparoscopic appendectomy, should we staple or use a loop closure technique on the appendix? And should we invert or dunk the appendix or not? These questions and many others have developed some degree of consensus, but there's always more questions to be answered. The question is appendicitis truly a surgical disease all the time or some of the time? Now, it's a pretty common diagnosis. It's the most common presentation of acute abdomen with a 7 to 8% incidence lifetime. And most of us have read this book, the Early Diagnosis of the Acute Abdomen by Cope, in some form or the other. This is actually a picture of a first edition from 1921, so the 100th year anniversary, and this is available online for the bargain price of $2,500. I am not selling it. So the World Society of Emergency Surgeons has put together consensus guidelines for the management of right lower quadrant abdominal pain. And here's their flow sheet for the pediatric patient. This is published in 2020. And clearly, non-operative management has found a place in pediatric appendicitis, particularly uncomplicated, with the main differentiator being the presence or absence of appendicolith and the overall condition of the patient. But what about adults? Can we carry these same guidelines over to adults? After all, adults are really just big kids, but clearly not. In fact, the consensus guidelines seem to differentiate between 40 and below 40 as being a key factor in determining whether the adult patient should have surgery, with the recommendation that over 40 should have surgery. But there is a potential here for non-operative management for adult patients too. In fact, this has been studied quite a bit in the last 10 or 15 years. There's numerous small trials in the literature. Most of these are underpowered. Many of them also focused on cost of care, but didn't really factor in factors beyond the initial hospital stay. The studies that are referred to the most is this study from Finland, which was published in JAMA in 2015. But this doesn't really reflect how we practice today. And in this database, there was over 95% of the patients who were operated on were done open. And I think we can agree that open and laparoscopic appendectomy are different operations. In fact, a lot of the complications noted in the surgical group were more specific for open appendectomy, including wound problems. What they did note in here is that there was a 27.3% failure in the non-operative or NOM group who underwent appendectomy within 1 year. This study was probably also underpowered and failed to show non-inferiority of antibiotics versus surgery, although the authors went on to conclude that there was a significant role for non-operative management. Although I would argue that a failure rate of around 30% is not optimal. Now, the CODA Collaborative is a more comprehensive trial done in multiple centers in the United States, published in the New England Journal of Medicine last year. This involved a much larger group of adults. Of note, of the 1,552 adults, 414 had an appendicolith, and that did seem to correlate in the study with increased risk of complications from non-operative management. Half of these patients were managed non-operatively, most of them as outpatients, which is a different way of looking at non-operative management, as it's not consuming a hospital bed. Of the patients who underwent appendectomy, 96% of those were laparoscopic, reflecting more real-world performance. This paper did note that the odds ratio was 2.28 for complications in non-operative management patients, and the authors concluded the appendicolith was the main factor in this. There was, again, a 30% non-operative management failure at 90 days overall. But again, the authors concluded that in selected patients, non-operative management is safe and effective. There are some unintended consequences looking at non-operative management, though. Malignancy can be picked up in appendicitis at about a rate of about 2.3%. Most of those are not perforated, which means they're potentially curable malignancies. And managing these folks non-operatively could certainly put a small percentage of patients at risk for undiagnosed malignancy that could present later. That's more of a theoretical concern. It hasn't shown up in the studies, but I think it is a real-world concern. This next article I've cited here is quite an interesting one. It only looked at privately insured patients. In fact, it used private insurance databases, but that allowed them to find data, and this was published in JAMA in 2019 for over 58,000 patients. A relatively small percentage of these patients were managed non-operatively, but that number does exceed the number reviewed in any of the other studies. The non-operative management group, interestingly, had a 2 times risk of appendicitis-related readmissions after initially being treated, and had a 1.5 times increased risk of having an abscess versus surgery. This study also very thoughtfully looked at the total cost of care, including outpatient aspects of care, and found that non-operative management was about $800 more expensive when factoring in all these factors. Interestingly, the overall failure rate of that select group that received non-operative management of acute appendicitis was only 4%. This is the lowest number I've seen in the literature, and with a longer follow-up of 1.7 years. Although the authors in this case concluded that due to the increased risk of complications and the increased cost of care, that surgery should remain the standard of care in uncomplicated appendicitis. So what are our conclusions? Well, non-operative management has a failure rate of upwards of 40%, depending on which study you look at, and it's clear that patient selection is key, particularly with the presence or absence of appendicolith. This can be done as an outpatient with careful protocols. The CODA study has shown that, but it may miss malignancy. Surgical treatment ultimately has a negligible failure rate. There's lower complications than non-operative management. There's lower complications laparoscopic versus open treatment also. And this also can be done as an outpatient. In this days of COVID and medical-related bed restrictions, I think we have to keep one eye on our utilization of resources above and beyond cost. And surgical treatment may be the fastest way for these patients to recover outside of the hospital. At least in my institution, non-operative management of acute appendicitis has faded away, with surgery being the preference, and that remains my preference also. Thank you very much. I appreciate the opportunity from the college to present this work today. Thank you.